Kavisha. Great. So, welcome to our fetal therapy today. The topic is a very difficult one. It's about uniparental disomy. Kavisha loves genetics, even though it's very challenging. So she did part one for us before a few weeks ago, and now she's going to be doing part two, uniparental disomy. So this is for the fellows. This is very important because you will be getting these questions either on your written or oral boards, especially the names of some of these syndromes. So hopefully try to understand it as much as you can. Genetic counseling students, the same, you will probably be getting these questions on your written board exams as well. I am sure Kavisha will be more than happy to share her slides with you. And I do want to say that our second-year genetic counseling students graduate next month, and this will be their last fetal therapy with us. We wish you the best of luck and stay in touch. We're very excited that you are graduating.
Thank you, Dr. El-Quatli, and thank you for helping me with this presentation. Today, I will be doing uniparental disomy part 2. So, as you may recall from January, we had reviewed the mechanism of action and explored the various clinical manifestations from chromosomes 1 through 11. For part 2 of the presentation, which is today, we will be reviewing chromosomes 12 to 23 and the X chromosome, prenatal diagnosis, and then subsequent therapy. I want us to briefly review terms since it has been a while since we last spoke back in January, so I thought it would be prudent to go over these terms, specifically uniparental isodisomy, or also noted as, or denoted rather, as UPID, and then uniparental heterodisomy, or UPHD. So complete uniparental isodisomy, as you may recall, means complete isodisomy. So that's 2 chromosomes that are identical with respect to all polymorphic loci along the entire length of the chromosome. Complete isodisomy implies both absence of recombination and meiosis II error. Now, complete uniparental heterodisomy involves the inheritance of 2 different sets of alleles that are present for the entire length of the chromosome. And complete heterodisomy implies an error involving segregation of chromosomes at meiosis I. So essentially, with isodisomy, you're inheriting the same chromosome from one of the parents, versus heterodisomy it's still from one of the parents, but you're inheriting the 2 different chromosomes. So now, again, because there's been several months since our last presentation and previous discussion, I want us to very briefly review the 4 overall mechanisms leading to the state of uniparental disomy. The first one is gamete complementation, which is depicted here. This occurs when there is a non-disjunction event in meiosis, leading to the transmission of 2 copies of a chromosome to the gamete, which is then fertilized by a nullisomic gamete lacking the same chromosome. As a consequence of meiotic recombination, regions of heterozygosity and homozygosity are typically found. The solid rectangle that is here indicates an imprinted gene inactivated on the maternally inherited copy. And I'll go a little bit into imprinting in the next slides. Inheritance of this gene from only the mother results in 2 inactive copies. Isodisomy may also lead to homozygosity for a mutation, which is listed in, or denoted rather, in the asterisk. Carried only by one parent. So what you can see is this in particular is an example of heterodisomy, because you see you have both, like you have from the mother, but you have both pairs. But if you look at the top, it's isodisomy because there is also recombination. So those genes are completely identical along the entire length of that gene. Does that make sense? Okay. The next mechanism that you'll hear of is trisomic rescue or correction. And it is actually the most common cause of uniparental disomy. The cause of trisomy is a typical meiotic non-disjunction event that happens in one of the two conceiving gametes. The rescue process that takes place in the cell then takes place in the cell of the trisomic conceptus. So essentially you have trisomy occur. So you have fertilization of the disomic oocyte with a normal sperm that then results in this like trisomic conceptus. And then you'll have loss of the paternal chromosome, for instance, in a somatic cell line that would then lead to maternal uniparental disomy in the derivative cell. In some cases, there can be up to 100% trisomic cells in the placenta, with most fetal tissues displaying a normal complement. And this will be relevant for our discussion of chromosome 16 in particular, so we will go back to this again. The next mechanism that we will be discussing is monosomy rescue. So monosomy rescue also comes into play following a non-disjunctional event. So if you have a nullosomic gamete, like an oocyte that's generated in meiosis, then the conceptus will also be monosomic because you're only having one haploid sperm that's coming together. So then you have mitotic correction that then takes place, and this is achieved by replication of a single normal homolog received from the other parent. In this case, you will have the uniparental disomy is considered to be isodisomy because it's identical. So this one for me is always the one that makes the most sense in terms of how to conceptualize this, because you have a nullosomic oocyte followed by a haploid. Okay, and the fourth possible is the mitotic error in the initial normal conception, leading to either trisomy or monosomy. In the case of a trisomy, this is followed shortly thereafter by loss in the cell line of the non-replicated trisomy chromosome. And in the case of a mitotic non-disjunction resulting in monosomy, this then you then have essentially like monosomic rescue. But in both cases, what you end up having is isodisomy. So those are the mechanisms, again, just for something for us just to be aware of. So now we're going to go through chromosomes 12 through the sex chromosomes. So to begin for chromosome 12, neither maternal isodisomy, paternal isodisomy, or heterodisomy of uniparental disomy appear to have any effect on the phenotype. There have been rare cases of UPD reported in mice animal models, but not really in humans. So for chromosome 13, maternal and paternal isodisomy or heterodisomy may be without any phenotype rather, except for cases of homozygosity for a recessive disease mutation. So that's essentially saying like, you could, because there's identical alleles, that itself increases the risk of a recessive disease mutation. But what we have seen from the literature specifically is that there's been cases of a phenotypically normal mother with paternal isodisomy who ended up actually having a child also with isodisomy, but had a normal phenotype. So what this tells us is that uniparental disomy for chromosome 13 does not have any like manifestation specific, which is not true for some of the other chromosomes that we will be reviewing. So for a uniparental disomy of chromosome 14, it's rare, but there have been over 200 cases reports in the literature. 2/3 of these cases are actually reported to be the result of maternal uniparental disomy, and disease manifestations are partly due to the fact that chromosome 14 does contain imprinted genes that have different level of activity in maternal and paternal chromosomes. Maternal uniparental disomy is associated with what is now known as Temple syndrome. And this is a rare genetic disease characterized by pre- and postnatal growth delay, feeding difficulties, muscular hypotonia, motor developmental delay, and mild facial dysmorphism, which you can see above in this image. So what we see is a broad, prominent forehead, a short nose with a flat nasal root and a wide tip, downturned corners of the mouth, and then micrognathia. Additional features also include childhood onset central obesity, premature puberty, and variable born abnormalities. Now, paternal uniparental disomy, on the other hand, is actually associated with findings that we can see on ultrasound in the prenatal period, including polyhydramnios. There is an association with low birth weight and premature birth. And what we find is that these patients will actually have a bell-shaped rib cage, which you can actually see in this X-ray image. It really does look almost like the Liberty Bell in that curve. These patients also tend to have respiratory problems in the newborn, short arms and legs, ventral wall hernias, with learning difficulties and feeding difficulties. And some cases have noted characteristic facies, although I wasn't able to find images of those cases, but we'll see a protruding upper lip, small vertebral fissures, hairy forehead, and a short. Now, chromosome 15 is personally the one that I find the most interesting because uniparental disomy of chromosome 15 is associated with Prader-Willi and Angelman's. Before I go into the genetics of these two conditions, I'll briefly describe these conditions. So Prader-Willi syndrome is characterized by severe hypotonia, poor appetite, and feeding difficulties in early infancy, which we can see described right here. And then this is followed in early childhood by excessive eating and eventually gradual development of morbid obesity unless food intake is strictly controlled. Motor milestones in these patients and language development are delayed. All individuals do have some degree of cognitive impairment, and hypogonadism is present in both males and females and can manifest as genital hypoplasia, incomplete pubertal development, and in most, infertility. Short stature is also common unless treated with growth hormone. And there is a distinctive, actually, behavioral phenotype that's important for to know, and this includes temper tantrums, stubbornness, manipulative behavior, and obsessive compulsive characteristics. Strabismus and scoliosis is also present in these patients in terms of facial features. So this slide right here actually depicts a newborn with features of Prader-Willi. So image A really is just showing that there is a need for respiratory effort in the neonate post-delivery. If we look at B, what we're seeing is the facial features of the boy. So we see a narrow forehead, fair eyebrows, bilateral epicanthus, flat nose with big nostrils, and a thin upper lip. In C, what we can actually see is that there's abnormal positioning of both the hands and the feet. And then there's in D, we see abnormal position of the fingers with the thumbs adducted underneath the index and middle fingers. We have flexed hands and wrists and clenched hands. Here we have small feet and toes. And then what you see in F is that there's genital hypoplasia with slight maldescent of the left testes. So management of this patient often involves in infancy special nipples or NG tubing feedings to ensure adequate nutrition. But then in childhood, there actually needs to be quite strict supervision of daily food intake based on BMI. So in order to limit the weight gain that can occur, you need to encourage physical activity in these patients. They need often hormonal and surgical treatments, growth hormone to normalize height. These patients are also in very increased risk of having type 2 diabetes, hypothyroidism. There's also much needed treatment for neurobehavioral and ophthalmologic manifestations, sleep issues, scoliosis, hip dysplasia, seizures. Often they have daytime sleepiness, so then you have Daphne. So it requires quite a bit of management and care. In adulthood, a residential facility for individuals with Prader-Willi is often needed to help regulate behavior and weight. Now, this differs from Angelman syndrome, which is the other condition that we think of in 15, which is seen in 1 in 12,000 to 20,000 of the population and is characterized also by severe developmental delay, speech impairment, gait ataxia, and trembleness of the limbs, and a unique behavior with a happy demeanor that often includes frequent laughing, smiling, and excitability. In addition, you'll often see microcephaly, and seizures are quite common in these patients. The most important thing to know, though, with this microcephaly is that they actually have normal head circumference birth, and there's no major birth defects. Often this diagnosis is delayed. Developmental delays are first noted at around 6 months of age. And because the features don't exist or manifest until age 1, often it can take years for proper diagnosis for this patient. Management is focused around the manifestations, with the most common frequent manifestations listed above. So again, we can see seizures, sleep problems, behavioral features, including excitability, frequent smiling, laughter, aggression, anxiety, motor delay, speech delay, and you can also have, feeding and GI issues. So anti-seizure medications are needed for these patients, accommodation for hypermotor behaviors, disruptive nighttime wakefulness. There's much behavioral modifications that are needed, physical therapy, occupational therapy, speech therapy. And then you need routine management for GERD, feeding difficulties, constipation, strabismus. Often they require surgeries, and often these patients do end up in adulthood also needing behavioral facilities eventually. So the genetics actually behind Prader-Willi and Angelman are particularly interesting because they represent perhaps the best examples of genomic imprinting in humans. The majority of the genes in mammals display a Mendelian pattern of expression, where essentially you have normal alleles inherited from each parent that are equally expressed. By contrast, less than 1% of our genes are imprinted, having an expression pattern determined by the parent of origin. And although DNA sequence of the imprinted maternally and paternally inherited gene alleles is the same, there's multiple epigenetic factors, so DNA methylation, histone modifications, and chromatin conformations that ultimately determine whether the imprinted allele is expressed or repressed. And so what we can see here, in this example, is that we have maternal imprinting, and the paternal is not imprinted. So that is what is transcriptionally active versus the image below where the maternal gene is what is transcriptionally active. So Angelman and Prader-Willi are essentially caused by absent activity of a genetic segment within the 15q11 to 13, which is depicted above. In Prader-Willi, the basic defect may be absent activity of a transcript on the paternal chromosome 15, which codes for a particular cluster of genes known as HB1185 of a small nuclear RNA, also known as SNO RNA, and that's depicted right here, the SNO RNA genes. Different components of the Prader-Willi phenotype might therefore be mediated by perturbed functioning of different targets of those SNO RNAs. So if one SNO RNA isn't working, they will have different manifestations. Now, Angelman, on the other hand, is due to absent activity of the UBE3A gene, again, which is on the same chromosome, which is located right here. As you can see by this image, the HB1185 for Prader-Willi and the UBE3A for Angelman lie in close proximity to one another on this gene segment and are both under the influence of what we call the Imprinting Control Center, or IC, which is depicted here. So what we are seeing is that this is the centromere of the gene or of the chromosome, and then following that, we have the imprinting center. Then we have the SNO RNA genes, which again is for Prader-Willi. And then we have the UBE3A for Angelman. So the absence of activity is either due to the loss or non-functioning of the PWS or Angelman syndrome region on one chromosome of 15 homolog. So when we think about loss, what we're thinking about is often due to an interstitial deletion or a classic deletion. And this can be due to low copy repeats on either side of the region that leads to non-allelic homologous recombination, leading to the deletion of that region. And the phenotype of Prader-Willi or Angelman syndromes depends on which parent contributed to the deleted region. So that's actually the most common cause of Prader-Willi and Angelman syndrome. So what we can see is that the classic deletion, 70% of the time, is what contributes to Prader-Willi. And for Angelman's, it's actually 60 to 70% of the time. But the second reason is due to non-functioning of genes in the region due to imprinting status and uniparental disomy. So what I mean by that is that uniparental disomy is the etiology for only 30% of cases for Prader-Willi and less than 5% of cases for Angelman's. So again, normally individuals have one paternally imprinted chromosome and one maternally imprinted chromosome 15. And the imprinting state of chromosome 15 is actually set and reset as it's transmitted down the generations. And the resetting is an epigenetic modification and dictated by the imprinting control center, which I had shown you guys before. In maternal gametogenesis, what happens is for instance, for Angelman's, the ASIC, or imprinting control center, has responsibility for initiating a switch from the paternal past chromosome to then switch it back to the maternal. So then you end up having both sets become maternal because the one that the mom received from her mom is already coded to switch to the maternal. In paternal gametogenesis, the serve is to basically switch the maternally inherited to a paternally coded switch so that the paternal that's being passed down are both like paternally inactive. Does that make sense? Okay. So in Prader-Willi, again, like I said, 30% of cases is due to uniparental disomy. And when you do cytogenetic studies, you'll see a normal karyotype. Both chromosomes are from the mother. So neither of the critical PWS region is expressed, and the functional lack results in the Prader-Willi phenotype. Majority of uniparental disomy has its origin in maternal meiosis 1. And so I just wanted to also reiterate a point that I had made in from a presentation back, the one I did in January regarding the maternal effect. What we know is that Prader-Willi children born to mothers under 35, the etiology tends to be the deletion. But when we look at patients with Prader-Willi that are born to mothers above the age of 35, the most common or often reason is uniparental disomy. And so we tend to see that both for Prader-Willi and for Angelman's. Interestingly enough,
do we see it for other
imprinted? Not that I think because it's so rare.
Yeah.
That they haven't really found that association.
Yeah,
but it's interesting that it's not a deletion, it's actually this uniparental disomy, but that makes sense because it has to do with the recombination that occurs.
Yeah.
And so that's actually, when I get to chromosome 16 next, that will also make more sense there too. What I also found was interesting with this was that the uniparental disomy form of Prader-Willi is associated with psychiatric phenotypes. So these patients tend to actually have more psychosis and bipolar disorder compared to the deletion type. And then the uniparental disomy in Angelman's. So what we know is that, again, less than 5% of cases of Angelman's are due to uniparental disomy. But again, we know that patients born to moms greater than 35, the etiology tends to be uniparental disomy. In Angelman's, both chromosomes are from the father, and neither chromosome expresses the Angelman critical region. Most cases involve post-zygotic origin of an extrapaternal chromosome, possibly following correction of monosomy 15 due to a nullosomic ovum. So that's something that we had talked about earlier when we were looking at the mechanisms. Phenotypes due to uniparental disomy are actually not as severe as with the deletion form in these children. So what we find is actually there's less frequency of seizures, and some are able to speak a few words. Otherwise, these patients really aren't able to talk. So interesting how different genetics can roll. Now moving on to chromosome 16. So uniparental disomy with chromosome 16 is significant in the setting of trisomy. So trisomy 16 accounts for nearly 1/3 of all trisomy spontaneous abortions and is therefore actually the most common autosomal trisomy in humans. Among clinically reported pregnancies, there's an incidence of 1 to 2%. While full trisomy 16 is lethal, mosaic trisomy 16 is the result of a post-zygotic loss of additional chromosome 16, and that one is actually viable. And 1/3 of these trisomic rescue cases actually lead to uniparental disomy, which is seen in this image. So you again have this trisomic rescue, And then you have a trisomy conceptus. So then the rescue leads to having biparental, and then we see a heterodisomy right here as a result. So again, in 1/3 of cases, the trisomy rescue does lead to uniparental disomy. Maternal uniparental disomy of chromosome 16 is also actually one of the most frequently reported uniparental disomies in humans, but a consistent phenotype is not obvious. There is, however, an association with fetal growth restriction and an elevated risk of congenital malformations, specifically cardiac defects, developmental delay, and maternal preeclampsia. Paternal uniparental disomy, however, has not been reported to have a clinical consequence. Now, maternal and paternal isodisomy or heterodisomy may be without any phenotypic manifestations, except for cases of homozygosity for recessive disease mutations. So we're not really seeing any imprinting disorders. This tends to be more in the setting of recessive disease mutations. So there have been several cases of uniparental disomy of chromosome 17 reported in the literature. Paternal UPD has been associated with limb-girdle muscular dystrophy, which is an autosomal recessive inherited disease that is associated with a specific gene known as the alpha sarcoglycan gene. And it's what this disease is characterized is by progressive muscle weakness and wasting, primarily affecting the pelvis and the shoulder girdles. Now, maternal UPD, on the other hand, has been associated with infantile cystinosis, which is an autosomal recessive disorder characterized by accumulation of intralysosomal cysteine, which is essentially caused by a defect in the cysteine transport across the lysosomal membrane, and this results essentially in proximal renal tubular dysfunction. Maternal UPD is also associated with congenital ichthyosis, which can then result in what we see here, which is like this dry, scaly, and thickened skin present. For chromosome 18, neither maternal or paternal isodisomy or heterodisomy appears to have any effect on the phenotype. There has been one rare case reported in the literature of complete paternal isodisomy on chromosome 18, leading to changes in piezo2 deficiency, which is Dr. Al-Quatli's favorite gene, which is why I brought it here, and resulting in arthrogryposis. Chromosome 19 also does not have any maternal or paternal uniparental disomy effect on the phenotype. There has been maybe 2 reports in the literature of twin cases, interestingly enough, with paternal UPD associated with dysmorphic features in development. Now, uniparental disomy of chromosome 20 is associated with 2 specific conditions. Maternal uniparental disomy is associated with Mulchandani-Boj-Conlin syndrome, which was first described in 2016 in a case series of 8 patients with intrauterine growth restriction and postnatal failure to thrive. All 8 patients had severe short stature with proportional head circumference and profound feeding difficulties, which we can see here. The disease is actually named after the CHOP providers who studied and discovered the disease and was also listed on their website. Paternal uniparental disomy, on the other hand, is associated with pseudo-hypoparathyroidism, which results in resistance to the parathyroid hormone, which regulates calcium and phosphate levels in the blood. It's also associated with obesity and short stature, and subtle bony abnormalities as depicted in the image above.
You just
Yes.
triggered, I think, in my frontal lobe, and now that Whitney's here as well. So last night at actually 7 p.m. there was a lecture on 22q11.2. Did you watch it?
No, but I did see there was.
It was amazing. And I think, like, again, that's another syndrome used to be called DiGeorge that, was kind of discovered in Philadelphia and CHOP related, pancreas, et cetera. And we should make sure that the fellows have, make sure that you guys, like, their free lectures, they are at 7 p.m., but they're really.
The fireside lectures, right?
It was just,
Top.
I was destroyed. I watched soccer on TV. They put it on. It was like, the lady was unbelievably good, and they've published everything about it, and it's just mind-boggling how good it was. It's like this you're doing today, you know, but it's just so interesting.
Chromosome 21, there has been no case or reports of uniparental disomy that have effect on phenotype. And this is the same for also chromosome 22. So there haven't been any cases in the literature for these two chromosomes that have any association with uniparental disomy and different manifestations. So I only put the X chromosome, which we have right here, since the Y chromosome is technically uniparental. So neither maternal or paternal isodisomy or heterodisomy of chromosome X appears to have any effect upon phenotype. And while uniparental disomy of chromosome X hasn't been noted, there interestingly though has been different neuropsychological phenotypes according to the parent of origin in monosomy X. So what they did, there was a study that was done in the UK of 80 girls with Turner syndrome. Of those 80 girls, 55 inherited the maternal copy and 25 inherited the paternal copy. Girls with the paternal copy were actually found to be more socially adept and more articulate compared to the girls with the maternal copy. And autism has actually been associated with the patients with the inherited maternal copy, which was really interesting. That said, again, there hasn't been a specific case reports or conditions about the specifically for uniparental.
The physical phenotype was the same for Turner syndrome?
They didn't really go into the details of that. The study was specifically really looking more at the neuropsychological, but it was interesting. And I would assume there has to be some physical manifestations because it's again, it's such a big range.
Yeah.
But it was interesting that they found these pretty consistent differences with the maternal and paternal copies. Which leads you to think there has to be more imprinted genes that we're just not aware of. This image right here, I think is just one
It's
for,
beautiful, really.
yeah, just for everybody to, you know, take a picture of, keep, but these are the disorders, uniparental disomies that have an association with congenital disorders that are known. Back in January, we had reviewed transient neonatal diabetes mellitus, Silver-Russell syndrome, and Beckwith-Wiedemann. Today, we went over Temple syndrome. We went over Angelman, Prader-Willi, and then the pseudo-hypoparathyroidism and the MBCS syndrome. So those are the conditions that I spent a little bit more time reviewing since they do have manifestations and are important ones to know for boards. So now we're going to go into prenatal diagnosis and management. The above is a schematic walking us through different indications for prenatal uniparental disomy testing and clinical outcomes. I will discuss the indications a little bit more in depth in the next slide. Once uniparental disomy, though, is noted on diagnostic testing, I think the important thing to know is that it could mean several things. Either there is a disorder disrupting imprinting, such as Angelman's or Prader-Willi. There is a homozygosity of a recessive allele. So that could be like cystic fibrosis or limb girdle muscular dystrophy, which we discussed earlier. There could be aneuploidy mosaicism leading to an unspecific phenotype, such as with mosaic 16, which we had just discussed. But most of the time, we'll have molecular changes of no consequence, as we've seen throughout the lecture. So again, with findings where we see uniparental disomy, but it doesn't have necessarily any phenotype. So to start, in patients, who should be tested for uniparental disomy? Should it actually be considered? And per the American College of Medical Genetics, the following patients should be considered for testing. Fetuses with complete trisomy or mosaicism in chromosomes 6, 7, 11, 14, and 15 on CDS or amniocentesis. They haven't included 20 in the official guidelines, although more and more case reports have been saying to include 20. Again, this is from 2020, these updated guidelines. But again, these are essentially what you can see, 6, 7, 11, 14, 15 are the conditions that, or the chromosomes rather, that have those known disease manifestations. Fetuses with Robertsonian translocation on chromosome 14 and 15 should also be tested. Both familial Robertsonian translocations and de novo translocations are considered to be at risk for uniparental disomy. Fetuses with anomalies identified on ultrasound consistent with uniparental disomy syndromes. And this can be a little bit difficult because a lot of the time we really can't make these diagnoses based on ultrasound. Newborns with neonatal diabetes mellitus, infants suspected to have Beckwith-Lehman syndrome, which we actually had just a few weeks ago, infants or children with features of Russell Silver, and patients with features of Prader-Willi or Jones. Now that we know who to test, how to test is the next question. So there are techniques to detect uniparental disomy are generally based on genetic polymorphism and the segregation of analysis between the proband and their parents. So in classical uniparental disomy testing, what we often use are short tandem repeat analysis. As a reminder, short tandem repeat analysis are DNA stretches containing repeat units of 2 to 7 nucleotides in length that are tandemly repeated. What we see in image A are short tandem repeat typing illustrated. So here we have maternal uniparental heterodisomy of chromosome 15. So again, you can see this is the maternal, this is paternal, and the proband has essentially identical to the maternal, but because it's carrying 2, it's heterodisomy and not isodisomy. Here we have uniparental isodisomy of chromosome 16, which you can see right here. We're seeing only one pattern being picked up. So again, that's isodisomy. And then this one is a little bit more complex because it's actually depicting mosaic uniparental. But that's more with a dosage effect. Uniparental disomy can also be identified through the use of single nucleotide polymorphisms, but these analyses require analyses of large numbers of markers as SNPs, which often consist of 2 nucleotides. Image B, what we can see demonstrates the detection of segmental uniparental disomy. And what you'll see are regions of homozygosity, which is seen in this purple. And then here you see the allele frequencies. Now, in families that are suspicious for uniparental disomy affecting the imprinted loci, you can use methylation studies. And that's depicted here in image C. An example would be for Beckwith-Lehman, where you test for both a gain of methylation in imprinting control region 1 and a loss of methylation. And that's actually demonstrated here where you have a gain of methylation and then here you see a loss of methylation. So with the implementation of non-invasive prenatal testing, or NIPT, there is much conversation regarding the detection of uniparental disomy on the basis of next generation sequencing based analyses for fetal cell-free DNA and maternal cells. Often, uniparental disomy is seen in the setting of rare autosomal trisomies, also known as RATs, noted on cell-free DNA. What we find, though, is that 1.5% of cell-free DNA results with rare autosomal trisomies actually represent true from fetal mosaic cases, and they do end up surviving to the 2nd trimester. And what we recommend is diagnostic testing because of the possibility of diagnosis of fetuses. And in cases of trisomy 6, 7, 11, 14, 15, and in this case also 20, identified by cell-free DNA screening, amniocentesis should be recommended. A CBS can be offered in these cases, but there is the risk of confined placental mosaicism, and the patient should be counseled that an amniocentesis may be necessary to confirm the diagnosis. Now, if the amniocentesis results are normal, then you would go to methylation studies to test for uniparental. Uniparental disomy can also be identified incidentally by regions of homozygosity noted on prenatal next generation sequencing. This was something that I had discussed in one of my previous fetal therapies back in November, so I will not go into depth. And then the final thing is, what if you do have incidental identification of uniparental disomy? So the incidental identification of uniparental disomy affecting and harboring clinically relevant imprinted genes does require comprehensive counseling. And this is complicated in cases of chromosomal regions with uncertain imprinting status, but even in cases of uniparental disomy that are not associated with imprinting, there is the risk of homozygosity for a recessive pathogenic allele. And this was seen throughout the entire presentation and back in January. Identification of uniparental disomy without clinical relevance might contribute to additional uncertainty. And so pre-test counseling, including benefits, limitations, diagnostic scope of genetic tests is very important. And ultrasound findings in genetic counseling are also equally important in helping guide patients' decisions.
Kavisha, remind me how you might incidentally pick up UPD on your like SNP-based microarray if you're doing a trio.
You would see regions of homozygosity
Yeah.
would be the big thing.
That's
you
what I
would end up seeing. But then it's the way you would be able to distinguish between, like for uniparental disomy, you would see long stretches specifically is what they would note, and that would sort of tell you that
And that would come back on a microarray.
correct. Versus short stretches could be more based on just similar ethnicities, could also be consanguinity.
Yeah.
And so those are the two big ways to distinguish.
Okay.
And then this leads me to the end. Any questions? And also congratulations to the second year genetic counseling students on finishing.
That was wow of a presentation, Dr. Khanuja. I
Thank
think you tried to make such a very complicated matter in genetics as easy as possible, and I think we all learned from this presentation today.
It's actually one of my favorite I love genetics, and I think it's one of my favorite things. This came out, when I was, it's been around for 30-some years, we've known about it, and it gets more and more interesting every lecture I hear. I have more of a ethical, anthropological, sociological thing. Like, you all think about your parents and, or your siblings or whomever, and you usually say, Benedetta is 50-50, father and mother, but not always.
No.
And I wonder if who you, can, obviously, this is an example, but you want, I always think about my brother. My brother is the spitting image of my dad, physically, character, just he's alive again almost. Yeah, and you always wonder, again, is it really 50-50, or obviously some chromosomes are more important than others. Some, it's not just physical, but really, some of us are at least, 48-52 or whatever, not 50-50.
I think what's also, I think what kind of demonstrates that is in the Turner's cases in particular, I found to be interesting because, we again, it's not necessarily an imprinting disorder, but maybe there are other imprinting centers that we just don't know about that can contribute to why, even if we're thinking, about the physicality, just why are eye colors we inherit from one parent and not the other parent, and hair and certain. I think also when you think about the social aspect, is what I found more interesting was how the paternally inherited X chromosomes, those patients tended to be more social, which tells me that.
Be the other way around.
I was thinking.
The other way around. Somebody messed up that guy's square or whatever. Yeah.
My dad is not social and my mom is the complete opposite.
Oh my God.
It is really interesting to see how these traits are, passed on and inherited, and how it's not necessarily the inheritance, but then how it's the epigenetics, which I think makes me more interested in the epigenetics than just basic inheritance. Because even this is just, this is simple Mendelian inheritance. It's the epigenetics that make it.
It's interesting. If you think about epigenetics, again, to get it's more philosophical, you actually can change your DNA during your lifetime, by epigenetic changes. And that has happened many examples in the literature, proven how depending the life stresses, whatever, you have, then you're going to pass on your genes, I guess, more imprinted, less imprinted, methylated, non methylated.
Right.
But so you're not changing the actual DNA, but you're changing the way it expresses, which really it's changing your genetic inheritance.
It's reset and set every generation.
Right,
which is also interesting.
Right.
Because it just continues to be modified within each treatment.
right.
Um,
Yeah.
and that could be why things manifest later in later generations.
Yeah.
And then may not manifest earlier, yeah.
Two things I wanted to add. One for Better Willie, because for the genetic counseling students, you may have this on your exam. Typically, unfortunately, these children, they have minimal pain perception. So they pick their skin, they may have burns on themselves. They wouldn't complain of pain. So, and typically this is the exam question would be like they may, if there's cuts on their skin, they don't report it. They are involved in aggressive behaviors, autism, obsessive compulsiveness, but self-injury also, and they don't feel the pain also. So remember this on your board exams. Now, regarding the X chromosome imprinting, we had a fascinating case here. A patient whose NIPT was monosomy X, and as you know, the part of predictive value for that is small. So we did for her an amniocentesis, which typically would just do a karyotype. And I think that case changed what I do, correct? Because, okay, there's two X chromosomes. We also ordered on her, though, the microarray, because we ordered it because we were looking for the copy number variant changes, which 0.42% in the general population, because she wants it as perfect genetics as possible for the baby. And with the microarray, what turned out to be is that actually the two X chromosomes were identical. So basically what happened is monosomy SQ, as Kavisha have mentioned, and the two X chromosomes were coming from mom. We spent with this patient maybe 3 or 4 times. We tried to reassure her as much as possible that there isn't a lot of imprinting genes, but as Kavisha have mentioned in her slides, there could be some psychotic manifestations. There's no way I can tell her the percentage. So yeah, that was a challenging case for us. And I think going forward, because of that case, now I order, I discuss karyotype and microarray with every patient with monosomy X, which is a common finding on an IPT. So, okay. So this is fantastic. Thanks so much, Kavisha, for all your teaching for us today.
Thanks
Any
for
other
helping.
questions?
No, I guess if neonatology is around, we can move to that if you
Yeah.
want.
Great. Okay.
Yeah, hi everybody, it's Dave. I'm here.
Hey, Dave.
Hey. All right, so we have had baby De Silva with us still. This is a 45-day-old former 30-weeker. This is a C-section for severe FGR, abstinent diastolic flow, and there was oligohydramnios as well. The baby's doing well on room air now. Highest respiratory support with CPAP. Is on full feeds, has a stable grade 1 hemorrhage on the left, and has retinal vessels haven't matured completely yet, so ophthalmology still following, but no ROP as of yet. Right, then we have baby Edwards, girl Maisha Edwards. This is a 34-day-old, 32-weeker. The C-section for non-reassuring fetal heart tones with also severe FGR. This baby was on a maximal support respiratory-wise of CPAP and is now down to 2 liters cannula. There was also exposure to oxycodone and THC, but the baby never developed significant symptoms of neonatal abstinence, and is also being followed by ophthalmology, but no ROP as of yet, and had a normal head ultrasound. We have baby boy Brittany Ferguson. Is a 66-day-old former 26-weeker. This was a vaginal delivery after a PPROM on the 23rd of January. Baby looks like delivered about 2 weeks later with preterm labor and chronic abruption. This baby was intubated briefly, received surfactant shortly after birth, and has now weaned down to room air. From an infectious disease standpoint, the baby was E. coli positive a few days after birth. So the initial culture was negative. And then I think a subsequent culture in that first week grew E. coli. So the baby received 21 days of cefepime for that infection. Had no normal head ultrasound and has stage 2 ROP that's being followed by ophthalmology. And is otherwise on full feeds and doing well. Then we have baby girl Sarah Friedman. This is a 30-day-old baby, former 24-weeker. There was a C-section for preterm labor with breech positioning. Mom actually, it looks like mom felt a foot in the vagina while she was at home and came in. The baby was on maximal respiratory support of the oscillator, was on the jet and the oscillator, is now extubated as of the 13th of April to non-invasive positive pressure. And this is in the middle of a course of dexamethasone, so we were able to extubate with some steroids. Cardiovascularly, the baby's been doing well, is on full volume feeds, had a normal head ultrasound, and should receive the first ophthalmology exam this coming Wednesday. So moving in the right direction. Then we have baby girl Ebony Grant. She is an 84-day-old former 26-weeker. This was a vaginal delivery after an induction of labor with concern for triple I. This was baby was on maximal support of a mechanical ventilation for about 3 weeks, and now is extubated, weaned down to 1 liter nasal cannula. We've been following echoes. The heart looks good. No signs of pulmonary hypertension in the setting of the BPD, and is working on feeds. Has a grade 1 IVH that is improving, and then has stage 2 ROP. And so the ophthalmologist is following weekly at this point, and otherwise doing well. Then we have baby Knight. This baby was just born 4 days ago. So this is a 24-weeker. Mom presented with had a cerclage placed from the 20th of March to the 14th of April. And baby mom ruptured it on March 30th and then ended up delivering on the 14th of April. And there was a diagnosis of triple I at that time. The baby's now 4 days old, is on the oscillator, had in the first day of life, had significant pulmonary hypertension requiring nitric oxide and elevated oscillator settings. The pulmonary hypertension has since really improved a lot, and we're now weaning on the oscillatory vent. So definitely moving in the right direction over the last couple of days from a respiratory standpoint. Is still on a little bit of dopamine for blood pressure support. Right now is in a little bit of acute kidney injury. The creatinine crept up, so they're leaving the dopamine on board to hopefully see that improve over the next couple of days. And then baby is working up on enteral feeds, and we'll have the first head ultrasound at 7 days of age, so in about 3 days. And then we have baby, I'm not sure how to pronounce it, PICH, pitch or pick, girl Sri. This is a 10-day-old former 33-weeker that was born by vaginal delivery after preterm rupture of membranes and concern for abruption. The baby's been on room air, is on full volume feeds. Blood culture was negative, and they're doing well. No concerns with this little one, just convalescing. And we have baby boy Tony Torres. So this is a 22-day-old 24-weeker, C-section for vaginal bleeding and preterm labor with breech presentation. The baby has been on mechanical ventilation since birth, it looks like, and is currently on the oscillator. They just started dexamethasone course for the baby and is starting to wean on the respiratory support. So hopefully we'll be able to extubate in the next couple of days. has been stable from a cardiovascular standpoint, is on full volume enteral feeds, and has a normal head ultrasound. It did have pretty significant dermatologic issues related to the 24-week skin. Wound care has been involved. Everything's starting to heal up now, and things are looking good. But that first week for these tiny babies can be pretty rough with skin sloughing, and this baby had it a little bit worse than typical. And I wanted to talk about baby Kearney. I'm sure many of you knew. I tried to print it on my sheet here, but unfortunately I didn't print. But baby Kearney was a 24-weeker. Mom was being followed in MFM with a cerclage, but ultimately ended up delivering at 24 weeks. Baby was doing well, and I think was about 3 weeks old until late last week, ended up passing away. It looks like it was from sepsis with necrotizing enterocolitis. It was a very quick progression. Margaret was the attending on, and the night prior had talked to the parents about how well the baby was doing, and then she got called to the bedside around 1 a.m. the following morning, and baby just very quickly decompensated. Grew Klebsiella from the blood, and the X-ray from the time of reintubation for the baby showed diffuse necrotizing enterocolitis throughout the bowel. So there was some, I think there was some thoughts from people reviewing the chart, specifically. Curry had told me about a few of the OBs that were concerned that the baby may have died because there was difficulty intubating the baby. But they were having trouble verifying the ET tube placement with CO2 monitoring. At like when we intubate, we use a capnometer that just detects CO2 real quickly. And they were having trouble getting a CO2 return on that. I think it was just because the baby's cardiac output was so poor and the baby was so sick, and the lungs were so de-recruited. But they did reintubate the baby, but the baby passed from sepsis and neck, unfortunately.
Do you think that the bowel ruptured, Dave? How did Klebsiella get into the blood? What do you think?
There wasn't any free air on the X-rays, so I don't think there was rupture, but there was a lot of air in the bowel wall and air even tracking up into the portal system. So it was a pretty significant neck. There weren't any indwelling catheters at the time either. So it's whether the bowel was populated with Klebsiella and it just jumped into the blood from there. It's really tough to say, but the baby hadn't perforated. It was just overwhelming sepsis.
Dave, forgive me, my ignorance. Is it common that the baby is like doing fine, and the neck just happens so quickly and so fulminantly? Like, I feel like that seems unusual to me, but
yeah, no, that's definitely rare, but it does happen. I've seen it a few times, and it really depends on the gram-negative bacteria in particular. They tend to go downhill very quickly because of the what the gram-negative bacteria release. And neck, just depending upon. I think it really depends on the vascular supply. So if a part of the bowel starts to necrose, and that happens to be higher up on the vascular tree, then you can get clotting there, and then ischemia very quickly to large segments of bowel. So I think this baby's bowel just became acutely ischemic throughout the abdomen, and did progress very quickly. So I have seen this happen before, but it's a rarer occurrence of neck. Yeah.
Did we know this patient ourselves? Did the mom have Klebsiella in her urine? How was her labor course?
we know her well, Huda. She's the patient that had the vesicovaginal fistula and then had the replacement of her cerclage. She did not. She had negative urine cultures, and she she did have like yeast, a persistent yeast infection, but this was not a yeast related issue.
Yeah. Okay.
Dave, we've been trying to keep in touch, with the mother. She
Yeah.
had bad outcomes in the past,
Yeah, I see. Yeah.
many difficulties during this pregnancy and after. Do you know the family? Do you know anybody keeping in touch or?
I don't know them. I wasn't on service while the baby was admitted. I know that Dr. Lafferty was on service with the baby and did have and was there the night the baby passed. So she had been in contact with the family, and I think was actually trying to reach out to them again this week.
Hey Dave, I'm here. I just logged
Oh,
on.
hey, Margaret.
Hey, I just spoke to Cynthia yesterday, to the mom yesterday afternoon. I was able to get a hold of her. And I know some other team members who were here over the weekend were in contact with her, as well as Zoe, our social worker. But I did chat with her a little bit yesterday afternoon.
We've been trying, from the OB side, MFM side, to be in touch with her. She has had some contact with Dr. Bender via Epic. Any suggestions for us in terms of more or less contact, how she's doing from your interaction?
She was very tearful and sad. Her partner was on the phone too, but was silent. He didn't say anything. And then his mother, so the baby's grandmother, was also on the phone. She was asking a lot of the questions. Cynthia herself seemed to be really struggling with the just sort of the shock of the loss, how fast it happened, and trying to understand why it happened. So we're doing our best on our end to support her in the grief and just sort of validating that yes, it happened so tragically fast. And they did agree to an autopsy, so that's in process. So, perhaps they might be able to get some more closure after the autopsy. I don't know. I don't know that I have any suggestions. It was she's talked to Zoe quite a bit, our social worker, and Zoe's the one who put me in contact with her because she had some questions for us. But so again, I don't know if I have any suggestions, but I know they're just struggling and very sad.
Thanks, Margaret. Thanks, Dave.
Sure.
Dave, do you have any other patients to go over? There was a 28-weeker FGR born after reverse diastolic flow and eventually decels.
Was that baby Walker, Vince?
We talked about it already?
No, was that baby Walker?
I think so. Yeah, I'm pretty sure.
Actually, I don't think that was on Amanda's list here. But I know the baby. We're doing well. Is
Just
on
for background, also for teaching and stuff. This was some chronic hypertensive, multiparous patient who had minimal prenatal care, but dates were okay. And what did she come in? Probably.
Chronic hypertension superimposed preeclampsia with severe features, severe FGR with reverse Dopplers. She presented and had a category 2 tracing, persisted throughout the night, and then she started to develop decelerations that were becoming more frequent, so we recommended delivery.
And in retrospect, I think what happened to this pregnancy is that she has 7 kids. Is she the one?
Remember her?
It's many, and she really had minimal prenatal care. And the couple of times she showed up, her blood pressure was always like 185 over 115, and she was not like fine with blood pressure medication. So I think she lived at severely high blood pressure throughout pregnancy, and that's why I think the baby eventually had placenta that was not functioning at all. Was one of the worst reverse diastolic flows I've ever seen in my life. And but how did the baby do, Dave?
the baby's doing well. Yeah, we received surfactant on the first day of life for RDS, and then extubated very quickly, and is on low pressure CPAP at this point. So far, tolerating feeds. So nothing unexpected at this point. baby's been progressing as expected.
Thanks.
Yeah, sure.
All right. All right, we can move to the next. I think if you guys stay on, Margaret and Dave will do the peri-viable guidelines as for schedule. Is that okay?
Yep, sounds good.
So the first change I made to this document is I adapted this table from the obstetric care consensus that kind of documents the different gestational ages and the recommendations for ACOG and SMFM in terms of intervention for those that are peri-viable. I'm happy. Would you guys like to read it yourselves? Do you want me to read? How do you think we should review the document?
I think if you can go over the main areas of controversy and,
Sure.
you know, Dave and Margaret, feel free to jump in. I know you've seen it for a couple of days. I would just, you know, go over the areas of controversy, especially 20 to 21 weeks, you know,
Sure.
kind of thing.
Sure, okay. I review everything from the table in the text, so let me just go to the bottom here and I'll start here. So all patients admitted to LND with preterm labor or other pregnancy complication during the 20th week of gestation or greater with expected or potential preterm delivery will receive a consult from the neonatology service. So initially this was the 21st week. I do think that we have some patients who come in, you know, in the 20th week with things, for example, like PPROM, who a lot of these patients do end up making it to viability. So I do think that a neonatology consult at the time can be helpful in making a decision on how they would prefer to proceed with the pregnancy. And I wanted to see what everyone's thoughts were regarding that.
Yeah, that actually jumped out at me. It wasn't so we had kind of taken the tack that there would be no neonatal intervention until the 21st week, and that was why we had decided as a joint group, MFM, OB, and Neo, when we drew this up originally, to just have us stop by on the 21st week, because there wouldn't be any decisions necessarily being made based on our input at that point that you guys couldn't inform yourselves. And what often happens is the parents come to us as sometimes after going to other institutions where they were told that they're not going to resuscitate, and then involving the neonatologist earlier on just adds another I don't know if we're not going to be intervening, involving our service, putting us in the position to be telling them that we're not going to be offering their baby anything, just has been fraught with I don't know, difficult conversations, difficult. I think it seems to complicate the situation more than just telling the family from an obstetrics MFM standpoint that unfortunately we don't offer resuscitation until the 22nd week. So neonatology won't be involved until that time. Now, when we get into the 21st week and we're talking about decisions as far as giving steroids at 21 and 5 and how those affect the neonatal course, then that's where we have historically gotten involved. Obviously we can talk about it more, but
I think one thing that comes to mind is I know that this document was drafted for the 21st week, and I think it was, I wasn't there personally, but I believe it was for baby night. That mother, she presented at 21 and 6. And I think the feedback I got after talking to the team is that, and correct me if I'm wrong, neonatology wasn't going to come see her until 22 weeks.
Yeah, until after midnight.
if that was in order to do a consult, prenatal consult, then that was the incorrect by our team. And I mean, this guideline is published. You can feel free to show it to anybody that refuses to come and see the mom in the 21st week. It's pretty clear on there, and I can talk to my team about it. If you guys happen to know who the particular provider was, I can talk with them. So I'm sorry if that was the case. We would not offer resuscitation until the 22nd week, but to do a prenatal consultation, the way that the document was written is in that 21st week. So we can talk about betamethasone and preparing for delivery.
Dave, to bring it back to like a 30,000 feet view, general discussion. We've had some 22 weekers at Jefferson survive, correct?
Yes. Very few.
Right.
Yeah.
And not 21 weekers.
Correct. There's been just a handful over the years, and it's probably been more of a surprise delivery. We're not sure the gestational age at the time, and then it kind of comes out from there. But those, we have not had any that have survived the 21 weeks.
Yeah, and right, I agree. Japan comes to mind, but there have been cases here and there. I remember the first one, it was in Florida, made the news. There were other ones, but I don't know if in our area nobody's at 21-week survivors, at least that I know of.
Yeah, the standard of care is still 22 weeks. There are places that offer lower, but yeah, I don't think there's been a move in the neonatology world to standardly offer resuscitation at less than 22 weeks, and I don't think that the survival in our area and across the U.S. yet is that really pushes for that.
So for this, coming back to this issue,
yeah,
we could, and I would stay away from like 20th week from I will keep it like 21 and 0 or 22 and 0, like you have in the line below. Maybe keep 21 and 0 as for neonatology.
Sure.
This is a living document. We'll always change it, but I think that's okay.
Thank you. So there's a lot of text in this document. I think I'll, like Dr. Brigella said, just focus on the stuff that's a little bit more controversial while we have everybody here. Let's see. So let's go down to this line where we talk about steroids. So going back up to this table, I know that here, antenatal steroids can be considered at 22 weeks based on ACOG and SMFM guidelines. I know at our institution in the past, we have offered steroids at 21 weeks and 5 days. And I wanted to see if that's something that we would like to keep in this guidelines. I'm going to go to the JAMA article that included 17 babies that did show that there was a higher likelihood of survival. So I think it's appropriate to keep if everybody agrees with that. And I can pull up the article too if we wanted to look at that.
I think that's fine. One minor thing, but just we used to do say fetal lung, but obviously steroids at this stage change neck, IVH, death. So I wouldn't call it fetal lung. I would call it just fetal maturation because it's a lot more than RDS or BPD.
Okay.
But yeah, I think if it's okay with the neonatologist, I think it's reasonable 21 and 5 for steroids. What do you think?
Yeah, that's
Yes.
yeah, I think that was a part of the original discussion, and yeah, if we're prepping for potential delivery and resuscitation at 22 weeks, I'd love to have the steroids on board, and I think that paper that Sonia mentioned supports that.
Thank you. Let's see, the next topic we can discuss. Again, ACOG and SMFM recommends starting magnesium sulfate for fetal neuroprotection, or we can consider it starting at 23 weeks. I know that there is also some data that supports If a fetus even at 22 weeks receives both antenatal steroids as well as magnesium, the outcomes are also better. I know there have been occasions where we have administered mag at 22 weeks. So do we want to keep in this document 23 weeks, or do we want to include 22 weeks as well?
I mean, I'll chime in, we have, for David and Margaret and everybody, the fellows and stuff, you probably know already, we have actually contacted SMFM and ACOG both, because the table here is from 2017, I think, the pre-variable guideline, and we have urged them to update it as this data that Sonia is bringing up, been published now for a few years. I personally, if neonatology is gonna possibly intervene, if we're giving steroids, I think that we don't have to recommend it, but I think we have offered it at 22 weeks, so we should change the guideline to at least follow what we have done already.
Okay.
Maybe actually the best thing is to go back to the table to see.
Yeah, so in the table, it's not recommended at 22 weeks.
I would say consider there as well, I guess make trunk changes.
Yeah,
Because
this one,
when
yeah, go.
just looking at 20 to 21, just going column by column, right? The only thing technically is latency antibiotics for PPROM that has been considered before 22 weeks. And some people even give it at 17, 18 weeks. I'm not a particular fan, but I know that's been reported. I think, we could leave it like this now. I guess any changes to this column, 20 to 21 weeks?
I think we can definitely discuss cesarean delivery as well.
And I think we would agree that this is not recommended before 22 weeks.
I agree with
We
all of
leave
the
this
first
as it is. We can leave, 24 and after, probably 23 and after the same, the big thing, I think it's 22 week and maybe. So neonatal assessment for resuscitation, consider we agree, we just changed that. Steroids consider, stop me, right?
Yep.
MAC considered. So tocolysis for preterm labor. To allow steroids, we do it everywhere else. I would probably give indomethacin for a couple of days. Somebody's
Easily if
22
we're
and
doing
3,
other
or
things.
once everything done, it kind of follows everything else.
I agree.
So consider at 22 as well, okay.
I think, again, this is all predicated on the fact that we're having a conversation with the patient about their goals and
Yeah.
desires, right? Like, not everybody is gonna want all of these things.
And antibiotics consider. Then Bishref prophylaxis. I think that's a minor intervention.
I mean,
We should.
I think you should consider it.
Yeah.
Yeah, like
Agree.
giving antibiotics for GBS probably isn't gonna hurt the 22 week.
What I actually, if I look at this, if I were sitting on ACOG and SMFM, I think they should have another row, they should have fetal monitoring.
Yes, they should.
Maybe we should put it on our, just before C-section. Can you add that? Can you add a row above C-section?
Continuous fetal monitoring.
Or fetal monitoring?
And I do have, I did want to discuss that as well. I have that here. We can go down to that if you want. And I think I was looking for some guidance here in wording, because I think a lot of this is individualized and based on a lot of factors such as the EFW, would we resuscitate, patient plan. So I think it's very hard to standardize all of this. So this is what I kind of came up with so far, but I'm looking for feedback.
Go back to the table and try to fill in.
Would not recommend below 22 weeks.
Yes. So that's
Let's
easy.
fill in the ones we know would be recommended, like 24 and
And
up.
24 and
recommend.
after,
Yeah.
recommended.
Yeah, exactly.
We want to do 23 weeks. consider.
But then it's like, do we?
But that's what
Maybe-
we've done. The lady actually with the cerclage and rupture membrane, we just delivered. We talked about it and she was okay actually with top tones that 23rd week. So maybe consider will be,
I think consider is probably the appropriate terminology with the like honest face value that I try pretty hard to not monitor babies less than 24 weeks and I try to talk people out of it. But I'm not against considering it and based on like, you know, the conversation a particular attending or fellow has with a patient.
But do we do like dop tones or?
I think this is like meant like CEF.
yeah, this is right. So maybe put an asterisk and say
Continuous fetal monitoring.
think you
top
mean-
tones.
I think you mean continuous fetal monitoring here, right? This is what you mean?
I think
Or
it means like an
NST,
NST 3 times a day. Yeah.
Versus continuous fetal monitoring.
No,
Or do you mean NSTs only?
I think just means, you know, TID NSTs.
Okay, because some people definitely.
Same
have-
here.
And I think in that paragraph, I try to.
Yeah, because I think some people may try to keep these babies on continuous monitoring. Is that true, guys? Is that happening?
I think for sure at 24 weeks, at 23 weeks, I think it just kind of depends on.
'Cause I just feel like we just need to be then specific about what we mean with fetal monitoring, because I sort of assumed we meant like continuous. which
I think we should.
Discourage.
Too many, like, you know, unless again, you know, abnormal Dopplers or whatever, I don't think we should do continuous.
I
monitoring.
agree, but I just wanted to make sure.
Right, so we should add it. That
Specify.
fetal monitoring, put an asterisk next to fetal monitoring, right here, at that beginning. Means, you know, NSTs, basically, whatever you wanna call it, CTG, intermittent.
Intermittent NSTs. And then I would probably say in that same sentence, something along the lines like CEFM should only be used in select, like circumstances or something like that. I don't know how you'd want to say
Such
it.
as FGR with reverse anti-solid flow, as an example.
Yeah, exactly.
Can I ask from the neonatal side of things, the reliability of, say, continuous fetal monitoring for assessing fetal well-being, is that the same across all these gestational weeks from 22 to 24 weeks?
No, I think that's the issue, Dave. You know, like
Yeah,
even at term, right? Continuous fetal monitoring is only beneficial in that it prevents unrecognized intrapartum fetal demises, but it doesn't actually predict any of the other things that we'd like it to do. And
Yeah.
that's in a term neurologically mature fetus. And so, you know, to try to extrapolate down to 20 to 25 weeker and say that it's gonna predict you know, bad outcomes is, I mean, I think that's not, we certainly don't have the data to support that, which is why I feel so
Yeah.
strongly that we shouldn't be doing it because it just forces our hand to respond to things that we wouldn't otherwise see, and we're probably not gaining we're not gaining benefit.
What about magnesium? They don't. Like if they're on mag at 23 weeks, isn't it a rule to be on continuous magnesium?
Should it? I mean, why? Right? Like,
Sorry, for the
So-
FGR with reverse and diastolic flow. like, I mean, I know this is all theoretical, but like, would this baby even be
Yes, great question.
right? Like,
Like, what are we doing?
can we even resuscitate? And like,
In that little
Maybe
paragraph,
say
the monitoring.
selects, like, in select circumstances, i.e. this after discussion with like neonatology or something, you know?
yeah,
like-
because like if it's a 200-gram fetus, then like, we can't even do anything.
So, when I go down here, like, I think a lot of this comes up here. I know. I think it's just so variable, so I don't even know if it makes sense to have a paragraph like this here because it's so dependent on so many different things.
I think it's good to comment on everything, but let's go back to the table and do the, because at the end, that's what people look at. So I will put a couple of asterisks here at 23 weeks for fetal monitoring and kind of put in the text what Dr. Bender was suggesting, something like, tones instead of NSTs are maybe preferred by some patient. I don't know, something.
Can I say like Doptone versus NST based on like shared decision making or something?
Sure.
Yeah.
Yeah, the way I'm kind of, this is a tough one because if the family is telling us that they want intervention, they want us to resuscitate the baby at 22 weeks, this is a very desired baby. They're weighing the morbidity, mortality for mom in the setting of a C-section, et cetera. And we don't have a great evidence base to say that the fetal monitoring is in predicting outcomes is different from 22 to through term. Why would we treat these babies differently? I'm thinking of a hypothetical scenario where we're just doing Doptones or we're not even monitoring, but the parents do want us to try to resuscitate. I'd rather not. I'd rather know that things are going downhill before something like maybe mom stops feeling fetal movement and then the baby's in a lot of trouble. And now we're trying to resuscitate and care for a baby that's in a much worse state than maybe could have been identified with fetal monitoring. I know it's a tough one, but
I hear you, Dave. I just think, I think the problem is that assuming that the fetal monitoring is going to show us something and that fetal monitoring is actually predictive are multiple leaps that we just don't have data to.
Yeah.
prove.
So that's kind of why I'm wondering
Yeah.
why we're differentiating these 2 weeks. If we don't have, like, if you told me, no, that it's not reliable, the heart rate variability is going to be different. Then I think we could say like, yeah, this, but
Yeah, I hear you.
I think a corollary to what we've
C-section.
been saying here. So if you go, so this is the 22 week.
Yeah.
Yes, yep. That one's the 22 week. And I know
So then here, maybe we would say Doptones only. Is that kind of what, I think that's what you had in your text.
I think the corollary to fetal monitoring is always, what do we do about the fetal monitoring, Dave? And I think that's to your point, right? It's if we saw what we might interpret as distress in a term fetus and perform a C-section for, are we going to interpret the tracing in the same way at 22 and 5 and perform a C-section for said distress pattern when we don't know if that pattern is actually just normal, right? Like for a 22-week
Yeah.
fetus, we know that
Yeah, yeah.
there's significant morbidity for mom with a C-section at 22 weeks. And, I know the data is changing, but it doesn't seem like, right, doing a C-section at 22 weeks still doesn't change long-term outcomes for these kiddos. It maybe gets you a live baby to the NICU, which I know is important, certainly important for some families, and I'm not trying to discredit that. And doesn't give them a long-term benefit.
significant maternal morbidity.
And if what you're seeing on the monitor, ultimately, if we could see into the future and find out that it was a transient issue,
Sure.
the mom's body is going to be much better at resuscitating a 22-week baby than we are.
Yeah.
So we are, yeah. I hear you. I'm just.
Yeah, I know. That's a tough question.
Yeah.
Dr. Gullerson had kind of reviewed this as well, and he had made a good point. What is the difference with, for example, if we're saying like 22 to 22 and 6, what's the difference with like a 22-weeker that's 3 hours from 23 weeks versus like someone that's 23 weeks, and should we include some of those nuances? So it's challenging to make like.
Yeah. We've kind of talked about it in the past, and it's just one of those things where if we don't draw a line, then
I think there has to be a line.
yeah, and I read his comments about FGR 22 weeker, like really tiny babies probably have a much higher morbidity, like a 300-gram 23 weeker is probably going to have higher mortality than a normally grown 22 and 4 weeker. Where do we yeah, but we're just kind of stuck and have to kind of draw a line at some point. All of the babies in this gestational age are going to have very high risk for mortality and morbidity, and so.
Another corollary is that, I always counsel, you guys and patients like that, these two things kind of, to me, go together, fetal monitoring and C-section, because the last thing I want to do is to do monitoring and watch the baby die while I'm not going to do anything about it, like a C-section. So, like, for example, if we're going to keep not recommended here, this, again, we could do daily DUP tones once, but no more than that. If we're going to say consider C-section, then that means that we should do more monitoring. But again, assuming we're going to take not recommended, then I would do once daily.
I agree with that. I think you and I sound like we might be on the same page in terms of the way that we approach care in the 22nd week. I think the question is, does everybody feel comfortable with not recommending a C-section in the 22nd week? I definitely do. I don't know if everyone feels that way.
And remember, this case is, we're talking about 22 and 6 versus 22 and 0. Guidelines are not meant to be, this is not the law. You go to prison if you break a guideline.
Sure,
you follow this 99% of the time, and then sometimes you're not going to follow this, which is fine. But at least, we have a kind of common ground. And, this will be reviewed at guideline meeting as well, and, with midwives and generalists and nurses, et cetera. But at least it's a better starting point. Dave, did you have any other major things in the document you wanted to discuss? Or I don't want to change the subject. I just want
to. Yeah, the one thing, actually, hold on one second. Let me just look through my notes here. Muti had put a bunch of comments, and I had written up some responses to those. He was wondering, there was a comment about having a discussion between the MFM and neonatology team about statistics before discussing with the parents. I do think that that's important, particularly because there has been some confusion on both ends. But one thing that stands out in my mind is I've heard from a few of the obstetric staff, like, well, can't you guys not put a breathing tube in this baby? They're only 300 grams or whatever. And I have yet to run into a baby that in the delivery room where we haven't been able to get a breathing tube in. We actually are stocking our 2.0, our smallest breathing tubes, which will even kind of open that up a little bit more. And it's very rare, even in these tiniest of tiny babies, not to be able to get them out of the delivery room and up to the NICU. So I think having a multidisciplinary conversation before discussing these things with the parents would be ideal, if at all possible. Obviously, if things are progressing quickly, then you got to do what you got to do. But and then one other thing that I've noticed.
Let me just make a comment on that also, because we have a lot of learners around. I couldn't agree with that more. First of all, there's a lot of literature saying that as sort of obstetrician MFMs tend to give worse, outcomes than neonatologists. And it's also because the neonatologists are the ones that see the babies after birth. They have the latest, national and local data, which is usually always improving. Then the worst thing is to, go in as a resident or something and say, your baby is a 20% chance of survival. And then neonatology goes in and no, it is 35%. And then the patient gets all confused. So I think it's extremely important in these very difficult situations to be on the same page.
Yeah. Great, thanks. And then one thing that's not covered in the document that I thought might be a good thing to talk about is transporting moms in for this care and the periviable. I think we had two in recent memory, and I think I had been involved with them with Meg. Maybe moms from, say, New Jersey who present there at 20 weeks. They aren't going to be able to offer them anything. They may even talk to them about not resuscitating to 23 weeks. And they mention, well, Jefferson will do it at 22. And so they think, all right, it's best to transfer mom over there to do the care. But nothing, correct me if I'm wrong here, nothing's going to change in the obstetric management of these moms in those weeks. And they end up coming to us and then wanting to speak to neonatology, wanting to get here and get different care than at the other institution. So what is it worthwhile coming up with some kind of part of the guideline that discusses how we talk to outside institutions that are trying to transport moms in for periviable care, is kind of what I was the end result of my rambling here. Sorry.
The neonatologists at Jefferson, New Jersey are from Nemours?
They are now, yes.
So technically they're all one group, I mean, in a way.
Yeah, that's been a very recent change, but I'm not sure of the gestational age at which they resuscitate over there. They're a different level of NICU. I don't think they take any babies, or frequently take babies less than 28 weeks. So the conversation might be different there, but I'm more thinking of even prior to 22 weeks, a mom presenting at 20 weeks. There's been a few that have been transported to Jefferson Center City and come expecting a different approach or different care, I guess. And it puts, I think, everybody in a little bit of an odd scenario where we're like, no, we're not going to be doing anything still for another 2 weeks, or we're not going to be resuscitating if you deliver for another 2 weeks.
I think what we could do, we could certainly share, we're the MFMs for Jefferson, New Jersey, and we need kind of, leads us there. And we could share this document with them, letting them know what to expect. Again, MFM care will be the same because we're the ones, but we are not their backup at night, meaning, we wouldn't go in. We would certainly answer their questions and direct care.
Yeah.
Dave, I think to get to your other point, which is that sometimes these patients get transferred, we get a call, or the general obstetrician gets a call from the transfer center. Hey, we have this patient at X, Y, and Z institution who's 20 weeks pregnant with advanced cervical dilation. We can't have her deliver here. Can she come see you? And I think your point of what sort of care are we offering those patients and what expectations are being communicated to the patient by transferring to us is a good one, because sometimes, right, those transfers are truly, is she a candidate for a rescue cerclage or exam indicated cerclage?
Sure.
Is she, is this real, right? Because maybe they got transferred from an emergency room who hasn't examined a cervix in a long time. And so we're verifying that information is correct. But I think that perhaps the onus is on us, right, as the accepting obstetricians, regardless of where the patient is coming from, to say, we are happy to evaluate her in triage for X, Y, and Z reason. We do not offer resuscitation until 22 and 0, and make sure that we are saying that verbally to the patient as the accepting physician so that they can also say that verbally to the patient prior to transfer.
Yeah, that's essentially what I was getting at. Yeah. I think the patients have come to us with different expectations because of what they've been told at outside institutions, and then they end up coming here and sitting without any change in their care. But I've gotten called to come and talk to them, and some of them have been under the impression that we're going to be doing something different as far as neonatal care or the time at which we'd resuscitate, et cetera. So to have a unified statement or something for our folks to refer to then communicate to the outside hospital our care. Yeah.
We could add a sentence here, Sonia, somewhere at the end, at the beginning, that transferring institutions and colleagues need to be aware of this obstetrical and neonatal standards, before
We're accepting.
transfers, so that we're on the same page, 2 points. Anything else, Dave or Margaret, you want to particularly discuss?
I don't think so. Those were the notes that I had. I'm not sure if Margaret's on service right now. I'm not sure if she's still. Yes, she is. Anything, Margaret, that she might have had to step away?
Yeah.
She's manning the delivery room today.
Anything from us, from around? I know, Sonia, that a lot of wordsmithing they need to be done still, but I think having done the table, hopefully the text can follow without us having to go through every word, and then
I can send it out again for.
send it out again to us MFM, and then once keep the track changes, and then with all those we can present it at guideline meeting, next month, whenever next one is. But it's a good progress. And we can actually send it to SMFM and ACOG. Maybe they can just follow our lead and make it the national guideline. They need to do this. I mean, it's amazing. There's fetal monitoring. It's not even on the table. Makes my point.
I have a quick questions regarding C-section recommendation for 24 to 24 and 6. Are we saying consider instead of recommended? Because I know in our practice.
Here?
Yeah.
So
Yeah, I think that's a good point. Excellent point. Recommend.
Right.
Really?
That's what she's saying.
I know, but do you believe that?
Up for discussion.
That's why I'm sorry.
I'm one little piece.
So we do that not uncommonly for fetal distress.
And again, some of this is not just getting to a guideline, but it's a lot more than that. Physiological, philosophical, ethical, religious, all kinds of aspects here. One thing that to me was difficult years ago to accept at some point was that once a 24-weeker is born and Dave is still on, they're going to go after their baby, and there's no. If the patient doesn't want to be resuscitated, she better deliver at home or somewhere else because they're going to go after their baby.
Is that the cutoff you use, Dave, to not offer comfort care? It's 24 and not 25?
Correct. Yeah, obviously, if there's other
other
anomalies
or something.
Yeah.
And was established many years ago. And obviously, that's the difference between mother, who should be the primary, decider, versus baby's outside of mom. We're kind of taking away some of mom jurisdiction, so to speak, or power. We could leave it consider, but I think it's an important conversation to have. How.
I think it's.
There's a paternalism in there. There's all kinds of things.
Yeah, the idea that we would recommend a C-section definitively at 24 weeks. I get, obviously, we want to. Then our NICU colleagues are going to definitely resuscitate a baby at 24 weeks. Then potentially giving them a baby that is less compromised is important. And again, the data suggests that C-section, right, in this periviable period might improve short-term outcomes. But am I wrong still? There's no data to suggest that these long-term outcomes are better with C-section at 24. It's not until after 25 weeks that the outcomes are definitely better. And so I think that there are certainly patients who are well-counseled who could benefit from a C-section at 24 weeks, either because they want getting to meet a baby alive is important to them, and having a baby that's alive to go to the NICU is important to them, even if I can tell them there's no long-term change. But to say we recommend a large surgery with significant morbidity for the mom when we don't have data, as far as I know, that it changes long-term outcomes, I really have trouble with that.
The data I found so far is just survival, not long-term.
Short-term survival. Yeah. So I that's where I have issue with recommend, in that column.
If it helps, I mean, our survival at 24 weeks years ago is very different than today. In our unit, we probably have 60+% for males and 70+% for females, and a very significant portion of them survive without significant morbidity. So it's just a very different discussion these days as far as 24-week morbidity and mortality than it was even just a few years ago. They're doing a heck of a lot better. I can't quote you the the differences in babies that receive a C-section or end up delivering vaginally or.
Is there newer data, Vince? Am I missing something?
I think there is always, newer data.
Of course, I'm
I'm
sure.
not aware of, can't quote it on my thing, but what I keep on thinking about, and I've told some of the fellows, but it's good to discuss it in the open, is that there are a few papers about OB willingness to perform a C-section and neonatal outcomes. It's pretty obvious. If you're gonna be willing to do a C-section, then maybe it's more of a chance of survival, and maybe not intact survival, and maybe dismal survival. But if you're not gonna monitor, you're not gonna do C-section, baby's gonna die. If you're willing to do a C-section and maybe monitoring whatever, then there's some kind of so there's a lot of paper on that. And now that we have those neonatal data that Dave just showed, plus some of the stuff that Sonia was talking about, thinking about these two things go together as well. Like I would even put consider or recommend. Remember that if somebody comes in at 38 weeks with bradycardia and she doesn't want to do C-section, we cannot do a C-section. So even if we recommend it, it doesn't mean that she needs to have it. We're not forcing anyone. We're just saying 24 weeks, 60-70% survival. We gave you steroids and whatever. I'll be okay with either. I don't feel strongly about it, but I feel more strongly that
They concur.
This to concur the same way that concurred everywhere else. And if we're going to monitor,
Period. I agree with that. I think they should concur. I still feel a little uncomfortable about the idea of recommend, but I am willing and I'm willing to go along with whatever the group consensus.
any other thoughts?
I think in a lecture with the Perinatal Society a couple months back, they used the word, survival focus, for these peri-viable, babies. So just to me, it just seems like, are we doing long-term, focus, or are we doing survival focus? And if we are on a mentality like the paper that you quoted, OB's willingness to deliver, if we're considering doing an NST for a 24-1, we have to be willing to do a C-section if recurrent, D-cell, what would we do, I think as long as those two align, I think in real practice, it will eliminate a lot of.
But I think considering is
inconsistency.
appropriate though, then for that.
Yeah,
Do you know what I
so you're
mean?
not like forced.
Then
You're not
we-
You
forced.
can just consider.
Should we do consider?
Because I think it's gonna depend on the counseling.
Yeah, and what the patient wants and the prognosis. Like
Because
small
for example, if
baby.
you have a 24-weeker who has severe FGR
Yeah.
and isn't at a fetal weight where you would, yeah.
But if the mom is requesting,
Yeah.
everything for my baby and I guess consider.
I'm fine with consider, but I have made my biases very clear.
She's not a bias though,
The way that I approach this is like pretty similar. And obviously, I hear what the patient is saying and take that into account when we're doing our counseling, but I agree that they should concur, and I'm happy to concur them consider or concur them recommend if that's the consensus.
Consider or recommend.
I I think consider, but I would love to.
Consider or recommend.
Recommend to be offered.
Let's consider.
It has considered.
I mean,
We write consider or we recommend for both?
I think you should be offering the patient.
so I think.
Consider or
But if
recommend?
she doesn't want it, we're not gonna.
So that's consider.
Recommended means
But then
like you're
again,
telling.
If you're
the
offering,
patient.
you're considering.
But then.
If you're recommending, you're recommending.
But when you put consider, there'll be provider that will not offer, right? Cause you have a choice, provider has a
No,
choice.
because I think not recommended means the provider is not recommending or giving the option. Consider means you're giving the option, but sort of discussing the risks and benefits with the patient.
It doesn't mean that you don't get, doesn't mean that you don't have the conversation with the patient.
That's-
Okay,
you
I
still
think
have-
Sonia needs to go. It should be next door and she's already very late.
Oh.
Consider or recommend?
Consider.
Consider.
So they're both considered, then I think I'm okay with that. Like if fetal monitoring is
I think
considered.
you mean consider. I was hearing you talk.
Yeah, I
about
think
that.
so as well.
But then if
Okay.
the situation is-
Any other things? So can we let Sonia go?
It's a strong recommendation.
It's possible that you have you considered, you have the discussion.
Anybody
and
on
at the end of
Zoom
that
wants to
discussion,
say
you
anything?
have a strong recommendation based on the patient's preference or based on, and I think that that's fine. But I think the idea of going into a 20, I recommend you have a season. Feels really. That's. Yes.
I have a little thing about ethics in there too, like if after 24 weeks, the patient's declining, but we can review that later.
And as a plug, Charlotte and I are working on a provider survey for obstetricians and neonatologists to get at the way that we perform this counseling and see if it's different, which we obviously know it is, but also if it's different based on the provider's like personal background, both obstetrically and like spiritually, physically, like coming soon to an email near you.
Thanks for everyone's feedback.
Bye.
Thanks, we have.
Thanks, everyone.
Tough thing to tackle.
How do I get my email, so I can get my slides?
Microsoft Outlook, just type in Microsoft Outlook.
Microsoft Outlook here?
Yeah. Uh-huh.
And then,
Yeah.
but not Gmail. It's not-
No, that's not Gmail. You can click on that, yeah. And then top right, sign in or sign in right there.
Thank you. Is it okay if I do a few,
Of course.
is that what it was?
I'm so happy to be here. Never get to be here.
Like, this is the
Does it work,
I'm so. It wants you to say at
Valid
jefferson.com
email.
or at jefferson.edu. I have to run down and figure out something about a patient at ultrasound real quick. I'll be right back.
So, this is about, this paper we wrote recently about the follow-up to colors, basically. Let me see, let me share on can you guys see the slides on Zoom, I guess? And this is to say that this is everybody's contribution, and again, follow up the cerclage trials that we did publish now. And what I wanted to just make you aware, I don't know if we need to change anything in particular, but we basically submitted recently this IPD meta-analysis on singleton gestation without prior spontaneous preterm birth, adding the color trial that was just published, within the last month. And the history here is that kind of the first trial of modern cerclage was by Dr. Rust at Lehigh Valley, here in Pennsylvania, 2001. This is the Dutch trial, 2001. This is UK, Nicolaides, larger trial. This is a smaller trial we did here, also now, 20 plus years old. Then there's a Japanese trial in 2016. And then, again, Jefferson data and Italian data from Rome and Naples, I think, with Dr. Bolig. So we basically got the databases and we teased out the data to find out if cerclage in women with a singleton without a spontaneous preterm birth but with a short cervix works. And the idea of this meta-analysis is to also find out the cutoff, because as you know, in 2017, the prior meta-analysis without Bolig say that 10 millimeters or less, maybe there was some benefit from cerclage. And it's actually after that, ACOG, MFM, and ISWOG have come out either saying to consider or recommend, going back to the nomenclature we were using before, cerclage for singleton without proper birth with a cervix of 10 or less. And recently we have been doing that. Like when did we start, last year? Or
Yeah.
SMFM came out and said that, ISWOG came out, said that, and that's what we're doing this afternoon. 10 or less, we would offer a cerclage, no matter if they were open or not. So we went and got these patients from these 6 trials, and you can see, some were very little data, some were more. Usually was always in the second trimester, but some after 24 weeks. The cutoff were almost always 25, except the UK trial only used a very short cervices, and preterm birth was usually the outcome. And actually, we're registering Prospero, got everybody to participate, and this paper is now under review. So we may actually, I wonder how this paper will be interpreted by the reviewers and the editors. But at the end, you actually end up having 500 of these patients, of which, about half got cerclage and the other half got no cerclage. Their characteristic was the same, race was different. But again, these days, race, it's almost questionable if you should report it or not. Obviously, this was by chance. These were randomized trials. And usually 22 weeks in terms of gestational age at randomization, and 13 millimeters in terms of how short the cervix was. And about 2/3, the cervix was 15 or less. Only colors used progesterone. The other trials did not use progesterone. And some used indomethacin and pericerclage antibiotics, which I remind you, we put in our guideline to give indomethacin and antibiotics for somebody with a short cervix, even without a proper birth. So here are the results, and the results were non-significant. The primary outcome was less than 37 weeks by design. You can see that all the relative risks trended for benefit, 20%, 15% benefit, whatever. Not as strong a benefit as singleton with a prior preterm birth, those relative risks are usually 0.6, 0.7, but certainly a trend for benefit, which was not significant. They gained about half a week more, 3.5 days more, again, non-significant, and the rest was the same. Except that actually, as has been reported in most cerclage and well done larger studies, C-section is more common in the cerclage group. This is the forest plot, and you can see that actually most trials tended to have benefits for cerclage, more on this side compared to this side. The RAS trial was still one least effective, but there was a trend for benefit in more trials. And this is the renal outcomes, which unfortunately, again, these are all trials, so very few patients, very few trials reported outcome. You can see out of 266 or already 49 reported RDS or 14 IVH, so not really interpretable, very little data. What we had was weight, a little bit bigger in cerclage, but really not clinically significant. And NICU with a little bit more data, non-significant. And we had the most data, almost all of the data we did have on stillbirth and neonatal death. And again, 23% decrease in perinatal death, 3.1% versus 4.1%, but non-significant as well. So really the next few slides are the most important ones because we already do offer cerclage to women with a very short cervix. And this data confirms that. This is the latest finally after we've looked at this Excel files and recaps, et cetera, for many, many, many times. So you can see that the shorter the cervix, look at this relative risk, the shorter the cervix, the more effective cerclage is, which is now been reported every time, really, in the larger, better studies. So 0.61 is the relative risk and is significant for less than 6, so to speak. Less than 11, it's also significant. And this ones did not reach significance, 15.9 and 20.9. But you could see that there is a, 16 to 19% decrease in preterm birth is not significant. If we had, 10 more patients in each group or whatever, it probably would be significant. And, as I look at this data, I look back in years since, years ago, we used not to offer to anyone. Then we began to do randomized studies and it's creeped up. I think you definitely cannot make the case for 21 to 25 millimeters. It's almost detrimental to the cerclage in those. And the same trend for possible benefit is that the cervical length was short earlier on, less than 24 weeks, as we usually, do now. And obviously we have latch going on to evaluate the cervical. So, Whitney, this is the most important slide that I've shown.
Oh, good.
So I didn't miss anything. This is the IPD data that we have submitted, confirming that, less than or equal to 10.9 millimeters, there is significant benefit, and we're doing that already. Singleton, no preterm birth, very short cervix. The question is, should we at some point, creep it up to 15 or 20? This is not significant though, but certainly looks like a benefit. And at 21 and after, there is no benefit. And the last slides I'll show you are this, actually, before those, I'll show you some survival curves. This is the same data looked graphically. Again, cerclage is shorter everywhere. It's just, more pronounced the shorter the cervix. And, but you can see, that there are some differences, albeit minor ones. And thank God, preterm birth, the longer cervix in general, the less the preterm birth. But there's still plenty of preterm births. Even at 18, 19, 20 millimeters. And the last piece of thing before I open it up, So these are, Rupture generated the survival curves. So very significant. I mean, it is as obvious as you can make it, cerclage in light blue really prolongs pregnancy very significantly. 10, very significant, not as, dramatic, but certainly a big difference. And then, which is, I think, the thing for most discussion, this is still significant. So 15.9 was significant. So there was a prolongation in latency, looking at statistically this way, which, we had seen trend before, looking at the data in different ways. And then 20.9, this p-value that haunts my life, 0.09. It's not significant, but you could see, some difference there. So I think that's the last slide. I'll tell you the bottom line, since we're also at the end of the morning. I think I'd be interested to see how this gets received. First of all, it may get rejected to begin with. Who knows who will publish it? And, I think it reinforces that, less than 11, you should place a cerclage, which is good because that's what we're doing. Now, with something like this, what I'm showing or the slides, is this enough, to move it to a slightly longer cervix? I think my crystal ball, you guys in 10 years, 5 years, it's just a matter of time. They're doing a trial. I forgot where, in China or Malaysia or on the only other trial I know. I think as more data comes in, I think, we will be doing this. I don't think we should change ourselves today based on non-published data. But I wanted to present it so that it was on your radar screen and we could begin to have a discussion about it, and the prior meta-analysis 2017, it took 4 years till the first guideline reported it. It was quoted by 400 citations, like very cited, made a lot of guideline, but eventually, it takes years for things to change. I never want to be the first in a way when things change. I don't want to be the last either, but
Can I ask a
that's what we
question
have.
about both this one and the next curve?
Yeah,
So it almost seems like the way I look at both of
Yeah,
them,
cool.
and correct me if I'm wrong.
yeah,
Right, there's like a group of people, two groups of people here, right?
Yeah.
Who, like, that's not all that different between
Yeah.
cerclage and no cerclage, who aren't gonna get that much more time in pregnancy regardless of what we do for them, right? And then there's this like large swath of people here who clearly benefit from having a cerclage versus no cerclage. And I wonder if there's something different about this cohort of people versus this cohort of people or this cohort of people who are, you know what I mean, at the end who don't, I don't know if that,
I
it's
think-
like, does that make sense as a
Yeah,
question?
makes a lot of sense.
Okay.
I can tell you that, I haven't looked at, maybe no exaggeration, probably hundreds of the survival curves with cerclage, no cerclage. Cerclage probably increases bed outcomes in the first 2-3 weeks. It's a foreign body, you may rupture membrane, you've been there, you've seen it too, Again, somebody rupture membrane, we've seen it recently, somebody goes into labor, somebody's illustrated, whatever. If they stay pregnant, then later on, in general, you have benefit, because you don't have a complication. So it's not always that way, and these are not thousands of patients, but yeah. It's just, it's just amazing how, this makes a big difference, in the less so, later on. I'll let you know, obviously, when we get reviews, but if and when we get reviews back.
You submitted to the green or
No, I actually submitted to the big journal because now I submitted it.
straight to pink?
Any comments? Any?
Can you show us the 10 again?
You sure the what?
10 millimeters. Yeah, I think didn't we already change our practice and we're doing
Yeah, we did. So this
and
confirms,
this is
Amanda,
just
that
reinforcing that
the
information
10
from the
millimeters
systematic.
is significant. You know, no matter how you look at
Yeah, this
9
is
or less,
wonderful.
it's always significant. So that's good. You know, the question is, you know, this relative risks, you know, that show some benefit, at least transfer benefit up to 20.9. You move it, you know, to especially to the 15.9, because 15.9 on the survival curve is significant. It's amazing, you know, we looked at this data so many, you know, if you change a patient here or there, then this loses significant or makes significant. Clearly, cerclage is more efficacious in people who have had a prior spontaneous preterm birth and they have a short cervix, because the relative risks are all better or like stronger or lower. But here you can make a case that it also makes a difference. So we keep our guideline as it is. You guys are aware of this, and you know, we'll go from there. I'm obviously, you know, in a way almost itching to go to 15.9, but I don't think we should do it till this gets digested a little bit more in the literature. I just wanted to show you first. Excellent. Anything else you guys want
Sorry, I
to
have one other question.
discuss?
We might not have the data to know that, but like how many of these people at less than, you know, 15, if we had done a follow-up, not done a cerclage, done a follow-up cervical length on them, like let's say a week later, how many of them would have then been in the 10 group and gotten a cerclage anyway? You know, we might not have the numbers to answer that question, but.
In this data set, we don't, because they're old. You know, 4 of the 6 are 20 years or older, and so I only have, you know, the shortest cervical length, and that's at the time, you know, they were randomized. I'm not sure in those trials people did see cervical lengths once we're short, but we could have it in our. There will be a retrospective. Which I'm going to write down for the next student whoever interested. We could look at our data. So the question is 11 to 25 millimeter, no prior cervical birth, how many short? You know, Rupsha did a similar study, but a little bit different, and now a few years old. We could recreate that data and see how many. Let me go back to, that's a good question. So this is, you know, the thing that haunts me as well, you know, this is preterm birth, less than 37 weeks, 40%, 41% patients without a preterm birth, with a cervix of less than 21 millimeters, 41% deliver preterm. But that's still a humongous amount of patients, you know what I mean? It's just large amount of patients. And if you look, you know, overall, you know, like 19% less than 32 weeks, that's a lot. It's not that much better with cerclage, it's a little. Yeah.
Let me ask.
Yeah.
What if a patient came to the ER with a cervical length of, say, 12 millimeters?
Right.
You would, under no circumstance, you would not do a cerclage with her? Just because it's.
We try to, you know, for 30 years I've been here, we try to, yeah, we try.
I mean, you wouldn't do it you wouldn't do something which is off, like a little, off the boundaries.
So my whole life, Alessandro, has been dedicated to try to be on the same page, because again, you know, what about, you know, 3 weeks ago when I first saw this, do I then by myself, you know, change it because I know this? I'm not sure. I don't think that's correct, you know, because this isn't, again, gone to peer review. They haven't looked at it. Even if, co-authors have looked at it and many, it's not just me, it's many people have double checked this data. And it takes time to make a change and you want to make it, together, because I know, it's not only in Italy, in the US, in many places, if Whitney offers it and I don't offer it, and Amanda, it's just no good, for the patient, for the learners, for clinical care in general. In 5 years, is this going to be done 12 millimeters? I don't bet, but I think we'll have enough data by then. But right now, 12 millimeters, we will probably follow her in a week and just wait.
Weren't we also for that specific population of 11 to 15 planning on doing an
Yes.
exam spec?
Correct.
And
That's what an exam says.
yeah. There was a big percentage that worked out.
Yeah. Yeah, it's interesting how, this evolves continuously and almost hard to keep up, but I just want to make sure you guys are aware that we discussed it, and I think there's a great research idea, even we must have a few people with 11 to 25 millimeter focal length, and in the last couple of years, we followed a lot more, and we could easily find out, because that could guide us. Like if you knew that at 20 weeks, somebody with a 12, 80% of the time will go to 10 or less, then why wait? That would be another
point in favor.
point in favor. Versus, if she doesn't change, then don't do it.
Let me know if anybody's interested. Happy to help.
Yeah. No. I will pass it on. Very good. Time and space. Anything else? Obviously in flow. Anything else you guys want to discuss? 11:47. Good.
Thanks, team.
All right. Very good. Excellent morning. Thanks. I think Christiana is going to send us fetal reduction.
Good.
So it says that they don't really do it there. But yeah, they have. That's what I was thinking about reduction. I think that he asked me.
Oh, yeah.
Yeah.
That's
Yeah, the
Problem,
patient
yeah.
issue. Yeah.
Did you guys talk about topics for education for next year? Have y'all compiled some ideas?
Sophie has been, I think,
Working on it?
Yeah,
Okay.
working on that. I think like she was gonna take the.
Yeah, right, you told me
on that.
education lead.
Yeah. But she had texted her, and I just don't know if we really responded to her, but.
I'll wait for her to come back for her vacation. You guys, yesterday for Wednesday lecture, did you all listen to that? Syphilis stuff, yeah, I listened to it, it was really good.
Which one?
There was like just a fellow lecture series on syphilis and pregnancy.
Oh, really?
yesterday.
Okay. Yeah. I saw that one.
Yeah, Tennessee.
Kids are good?
Yeah, they're good. I didn't see them this morning, but they were good when I left last night.
Yeah. Right. Yeah. Yeah. I was gonna ask you.
Well, so I'm sure she does the same thing that,
See you, take care.
That my grades were at work in those two questions. She is that my top 5 strengths are 1, 1, 1. She doesn't think